Welcome today to the Future of Bradford District Healthcare event. It's fantastic to have you here this evening, and it is fantastic to have our brilliant panel with us as well. So I'm going to give you a bit of an overview of what to expect this evening, and then I'm going to ask the panel to introduce themselves. But I will start by introducing myself. So I'm Tina Lafferty. I am the Programme Director for the Bradford Health and Social Care Economic Partnership. So my work really is about leading workforce transformation across health and social care, and clearly digital is a key part of that. So I'm really pleased to be here this evening and hosting the event for you. As I said, I'm going to introduce our panel in a little while. They will tell you who they are. They'll tell you a little bit about what they do. They'll tell you about what they think about the future of healthcare in Bradford. And then we're going to move into a question and answer session. So a number of you have sent questions in advance, and that's really good. That's really useful. Thank you. I've got those. As you're listening to our panel, if you think of any questions that you would like to ask them, if you can please pop them into the chat. We will be scanning the chat throughout the session and pulling out questions, as well as looking at the questions that you've already sent us. So please make best use of that. We are also going to be having some polls running throughout the event. So those polls will pop up on your screen. So when they do, if you can please just submit your views, and then we will get the results of those polls throughout the session as well. And I think the last thing I wanted to say really before I get the panel to start introducing themselves is that we're really aiming for a chat today. So recognise that this is an online event, and with online events sometimes we need to do a little bit of chairing. Sometimes the panel might feel that they need to put their hand up if they want to come in on a particular point, and that's all okay. But we really are aiming this evening for us to have a bit of a chat. And to really get across the key points to the questions that people have asked us. So I think without further ado, I'm going to hand over to the panel. I will start with Dr. Liz Breen. Liz, if you could please start by introducing yourself. So tell us who you are, your area of expertise, the project or the organisation that you represent, and then a bit of an elevator pitch around the future of healthcare as you see it. And if that was too many questions in one go, I'm happy to repeat it again.
It's absolutely fine, thank you. Good evening, everyone. So as Tina has just introduced me, I'm Dr. Liz Breen. I'm a reader in health service operations based at the School of Pharmacy and Medical Sciences. My other part of my role is that I'm a director of the Digital Health Enterprise Zone here at the University of Bradford. I think it's very much with that hat on that I'm with you tonight. So I'm looking forward to being able to talk about developments within healthcare, some on the digital side, but some on the service improvement side. And within the Digital Health Enterprise Zone, we offer sort of opportunities to further and advance research agendas, working with our local partners in healthcare, but also how we train and how we progress our students to be the healthcare professionals of the future. So I'm looking forward tonight to the conversations that we have and the chat that we have, just to see your views on what we can do with regards to the university engaging with that agenda.
That's brilliant. Thank you very much, Liz. Dr. Sohail Abbas, if you could introduce yourself next, and I'll go through the questions again. So it's who you are, your area of expertise, the project or organisation that you represent, and then a little bit about the future of healthcare as you see it.
Thank you very much, Tina. So I'm Dr. Sohail Abbas. I'm a GP. I'm a GP in Bradford. That is one of my role. I am a director in the Bradford District and Craven CCG, a director of population health and well-being, and deputy chair of the CCG. And I'm also the chair and SRO, that stands for Senior Responsible Officer, I think, for the West Yorkshire Health Inequalities. So different roles. So as a GP, I'm working as a frontline clinician in a very deprived inner city practice in Bradford. As a CCG director, I look at developing the services appropriate for our population in collaboration with the population. And then as a in my West Yorkshire role, I'm working on the agenda of health inequalities. So in terms of the future of healthcare, I mean, our place strategy, and colleagues have some, know it is to improve population health across Bradford District and Craven, and to reduce the inequalities in access, outcome, and experience of care, and reduce those inequalities in our population. And essentially, we are aiming to do it together. We are health and social care working in partnership with communities, with people, with voluntary and community sector, with institutions like University of Bradford, acting as one, and truly, working as an integrated care system. So that is the future of healthcare in my part of the world. Thank you.
Thank you, Sohail. And actually, some of the points that you've made, I think, resonate with some of the questions that have come through. So we may well come back to some of those things later. And you have just reminded me of something else, actually, is the use of acronyms. So we are going to try really hard tonight to not use acronyms and to speak in plain English. But if we do use them, because we all slip up and use them sometimes, everybody is welcome to ask in the chat, what does that mean? Because we quite often don't know what they mean, don't we? And sometimes we feel like it's inappropriate to ask. So thank you for that reminder. So I'm going to hand over to Dr. Paul Rice next. So again, Paul, it's who you are, your area of expertise, the organisation or project that you represent, and then a little bit about future of healthcare as you see it.
Thanks, Tina, and good evening, everyone. So I will start with an acronym and then I'll break it down, I think. So I'm Paul Rice. I'm the CDIO, which means the Chief Digital and Information Officer for Bradford Teaching Hospitals and Airedale Foundation Trust. And I also lead the digital program at Place. The chief bit's irrelevant. The DIO bit really means that I'm responsible for a lot of the enablers that Liz used the phrase earlier on, digital and transformation. I see them as very much kissing cousins. I'm responsible for a lot of the opportunity that digital presents in terms of the way in which we organize and deliver services. Some of those are services inside the hospital. Some of those are increasingly using virtual technology to offer services where people don't have to travel to the hospital or hospitals. The information bit is, I tend to talk about the plumbing and what flows through the pipes. So a lot of the infrastructure stuff and a lot of the enablers is about the plumbing, if you like, if you want to use a domestic example. But what we're really interested in is the quality of what comes through those pipes and what we can learn as a consequence of that. And I'm sure Rosie will have quite a lot to say about that momentarily. In terms of any other sort of context setting, I'll pinch from one of my colleagues who relatively recently said, there's no such thing as a digital strategy. There's just a strategy in a digital age. And I think that's what I'm talking about tonight. I'm talking about the fact that we have expectation, we have opportunities, and we've got challenges out there. And we've got an opportunity to look at the lessons, insights, and learning, not all of it positive, I hasten to add, about the internet age and what that is, what does that present for us? And I'm sure we'll turn round to topics later on around cybersecurity and threat and protection of my data, and challenges around things like inclusion and skills. So broadly speaking, that's my portfolio, that's my relationship with colleagues in the city. And like Sohail, I also work strongly under the Collective Act as One banner, because we're all interested in making sure that the health outcomes for the population of Bradford going forward can improve.
That's really helpful, thank you. And I'm conscious that there's a few people that are just starting to join us now. So we're just introducing our panel at the moment. And we would encourage you, as you think of questions, that you put them into the chat. Some questions have been sent in advance, and we will come to those a little bit later on. But if there's anything that you would like to ask the panel that you think of whilst they're introducing themselves, please pop those questions in the chat, and then hopefully we'll get to them at some point during the session. So next, I'm going to hand over to Professor Rosie McKeechan, and I really hope I pronounced that right, Rosie.
Nearly. Don't worry. Okay, brilliant. So I hope you can all hear me okay. I've got the dreaded unstable internet connection, but I seem to be here for the moment. So hi everybody, my name is Rosie McKechnie. I'm an applied health researcher and I'm a director of a research programme called Born in Bradford, which has been knocking about this city for over 15 years now. Born in Bradford is a long-term study following the health and well-being of tens of thousands of families living in Bradford. And what we aim to do is to explore why some families stay healthy and why other families fall ill. But crucially, we're not a dusty shelf academic research project. We use this information to work with our partners in the city to find better ways of keeping families healthy and happy. And I've got a poll, the first poll of the session, that I'm hoping somebody is going to magically pop up on your screen, which is to give me an idea of what you think are the biggest priorities that researchers should be exploring to tackle children's mental and physical health. And so this guess gives you a flavour of the different types of health factors that we study within Born in Bradford. So I'll give you all a little second to do that in the background. And I'm going to launch into my elevator pitch about what I think the future of healthcare is all about. So I actually think the future of healthcare is not rooted in our hospitals or our GP settings, but in our schools and communities. And why do I think this? Well, first of all, did you know childhood is one of the most critical times for health and well-being? So we know from evidence that the health and lifestyles during our early years and during childhood, as we grow up into adolescence, are intrinsically linked with health across the life course. So if we can get things right in early life, we're set. We're getting it right across for the rest of our population's lives. And did you also know that some of the world's largest killers, what we call non-communicable diseases, things like obesity, diabetes, cardiovascular disease, and mental ill health, cost the NHS billions of pounds every year. And yet many of these are completely preventable if we live healthy lifestyles. And this is a problem. More and more of our young people are afflicted by these diseases. So we know in Bradford, 41% of children aged 10 to 11 are overweight or obese. We know that 12% of young people in Bradford district have a mental health disorder. And we know that patterns of ill health is not equitable. So we know that children living in the poorest parts of our city experience worse health. So what can we do about it? Well, I would like to argue here that what we need to do is to look upstream at the factors in our environments, neighbourhoods and communities to see what we can do to prevent ill health occurring. For example, our Born in Bradford research has shown how important green natural spaces are for mental and physical health. But we've also shown that only one in three children in our region do not have a safe place outside to play. We know that children in the poorest parts of Bradford have a higher access to fast food outlets and find it really difficult to access healthy food options. So for these families, unhealthy meals are the only affordable option. Air pollution in our city is estimated to be responsible for 1/3 of children's asthma, yet those in most deprived areas are exposed to the greatest pollution. So we need to do something about this. And the way I would like to argue that we should be working to think about the future of healthcare is about working both with communities and in places to tackle these system-based drivers of ill health. So we need to bring communities together with policymakers, commissioners, schools and statutory organisations to jointly set priorities and work together to effect change. And we need to be able to evaluate the impact of these changes. And I wanted to just, in my last 30 seconds, tell you about our new Age of Wonder project. So this is going to be exploring these issues in 30,000 young people across the district over the next 7 years. We're going to be asking people what are their key health priorities, and then working with our partners to develop services that keep our young people healthy and out of formal healthcare settings. Community co-production is how I see the future of healthcare. I would be really grateful if somebody could now pop the video on, if that is Anna. So I've got a little video to show you that is going to tell you a little bit more about our approach and the Age of Wonder project.
want to make real change within our city, we need to move away from this individual approach where we're relying on people to make the changes. We need to take a step back and look at what's happening across the city and look at what's happening at a systems level to try and see what can we put in place to make lives better for our families. Communities are going to be so key in driving the change here. So that gives you a whistle-stop tour. And before I shut up, is it possible to see the result of the poll? Because I can't see it, and I'm curious to see what. Thank you, brilliant. Okay, that's really interesting. Thank you. That was my own bit of priority setting with you guys.
Thanks, Rosie. Wow. I mean, the stats are stark, aren't they? But yeah, and I think, yeah, it almost leaves me a bit speechless, to be honest. But it was quite interesting seeing the results of the poll. And I suppose that maybe a question to Anna and Hannah, but I'm assuming that those results are available afterwards. I'm going to make the assumption that all the results from the polls will be available afterwards, so that and be useful to draw on that after the event. Yeah, Hannah's saying yes, thank you. Okay, so I'm going to hand over to Jill, our final panelist for this evening. So Jill Bowskill, would you like to introduce yourself, please? And I'm just going to remind you what the questions are. So it's who you are, your area of expertise, the project or organisation that you represent, and then if you'd like to say a little bit about the future of healthcare as you see it, and I'm happy to repeat any of those questions if you need me to.
Yeah, I might need a prompt.
Yeah.
Yeah. Yes, hello everybody. My name's Jill Bowskill. I'm a patient rep really on this panel. I'm part of the university in that I have an honorary contract because I'm part of a group called the Service User and Carer Group in the university. I've been part of it for about 10 years. We get involved in some really interesting products in the university. We take part and help in the interviewing of future students. We do, we're sitting on management committees for prescribing. I sit on the ethics board for research, and we also do teaching in the university. And it's through our lived experience that we hope to help students in their delivery of their services. It's a soft way for students to get to know patients. They meet us first before they go out into practice, and it helps with their communication skills. So I feel it's a vital tool that the university have to break down some barriers for students. Probably my expertise is that I've had a long-term health condition, and through research, it's helped me attain some of the adaptions that I have, and through medication I have to help me live a better quality life. The future, what do I hope the future? I hope that research is continued to be funded, and also, and it might seem as if I'm a bit dog in the manger, technology is good in some areas, but in some areas it excludes patients. So I like to see the areas that they're going to use technology in health, that it's consulted with patients first to see if they can use it. I mean, during COVID, a lot of the times it's been on Zoom, hasn't it? And not face-to-face consultations or treatment. And for some patients, they just been able to access it because they haven't got a laptop, they haven't got Wi-Fi. So I think there's a big area for future development, but you've got to take the patient along with you to sign off these new developments. That's me for now.
Thank you, Jill. Really appreciate that, and some really valid points that you've made. Really important, and that's absolutely why you're here and involved in this work, isn't it? Because you certainly bring the patient perspective into the development of this work as we move forward. So I really appreciate you taking the time to be with us here today. Okay, so I am going to move into the question and answer session. I'm navigating two laptops, so I just have to bear with it. If I'm looking up here, it's because I'm looking at my other screen, so bear with me. So as I said, we have had a few questions that have been sent in advance, so I am going to start with one of those, and then I'm going to start looking at the chat and see what's in there as well. And we do want this to feel a little bit like a chat, so let's hope that we can make it like that. So the first question, and I denied whether this was the right one to start with, but so I'm hoping that I've gambled the right way. It's quite a big picture question, I think. So the question is, how has digital health changed services in the last 10 years? And then what about the next 10? Now, I think we've got lots of questions that start to focus more on the next 10, and I think some of that's come up already today, but I thought actually, maybe doing a little bit of reflection on how digital services have changed in the last 10 years might actually help us to think about the idea of moving forward as well, because I think some of it has been incremental growth, and perhaps we don't always give ourselves the time to take stock of everything that we have achieved in the last 10 years. So I'm going to open that one up actually and say, if anyone, rather than name anybody at this point, if there's anybody that wants to jump in to make a start, just any of your thoughts on how digital health has changed in the last 10 years. Paul, I'll let you make a start.
Just a couple of quick reflections. One, I don't think we'd have used those two words in the same sentence 10 years ago. I think we'd have struggled. I mean, Airedale has had pedigree around this agenda in their digital care hub for probably over 10 years. So I'm probably being slightly disingenuous there, but certainly not in common parlance. The other thing I did is I just checked, and slightly further back, but I should have done a poll like Rosie and asked people to tell me when they thought the iPhone was first introduced. So the iPhone's 15 years old this year. And if you think about how indispensable in many aspects of our lives the iPhone or similar products are available has become, then that sort of plots a little bit of the path around how these technologies have become ubiquitous, generally used. I think, and again, other colleagues can have a different perspective on this, but we're not digital natives. I'm not a digital native. I mean, I have an understanding and experience of before these technologies. My eldest son's 20 in July. He's no appreciation of life without them. So the other thing I would say was, in addition to that ubiquity, is that the extent to which, for a whole generation, these are things that they routinely use, intuitively use, access, and are comfortable and familiar with. And then the question is your experience of healthcare or health and care when this technology is involved or around, as seamless, as responsive, as user-friendly as, and sometimes it is and sometimes it isn't. Sometimes it's a bit clunky. So my only other reflection would be that we've come a very long way, but there is an absolute necessity to continue to talk to the people using these technologies, our professional colleagues, clinical colleagues, and to the people who are in the other side of that relationship in terms of service users, patients, clients, customers, whichever language people are comfortable with, about the value that it is adding and where it's adding that value. And in those circumstances where it isn't adding value, we shouldn't have technology looking for an opportunity or a solution. We shouldn't have a solution that says there's a technology, let's find a problem to apply it to. It absolutely needs to continue to be the other way around.
Fascinating. Thanks, Paul. That's a really good answer to kick us off, actually. I love that. But yeah, iPhones have been around for 15 years. Like, wow. And you think about the amount that's changed the way that we do so much, hasn't it? But I suppose I am mindful of Jill's point as well, that we've got that vast gap in age, haven't we, and use of technology. And I suppose that you made that point, didn't you, that we've absolutely got to think about patients of all ages in the application of digital health. So I'm sorry, Rosie and Sohail, I'm not sure which one of you put your hand up first, but Rosie, I'll
be brief. I'll be brief. So it was basically just to sort of follow on from Paul's comment. We do a lot of work with young people, and the phone is ubiquitous, and I can see how it will be a really useful tool for that generation. But it's just a note of caution is that it's not a one size fits all approach. So whilst I think there's amazing benefits for some groups of our society, it's not suitable for all.
Thank you. And Sohail, if you'd like to come in.
Yeah, and I think 10 years is a long time. If we just reflect on the last 2 years in COVID, I mean, look at what we are doing today. 2 years ago, we would not have been able to do it. Now it's a norm, these virtual meetings, these platforms, all that. It's just a tsunami of digital technologies in our healthcare system. And I think the next 10 years, I think that's the main thing. And what Jill said, that is the key. And as Paul was saying, digital is part of the solution. It's not the whole solution. So we have to keep it in that stage. And it's not going to, we can spend billions of pounds on digital, but if there is no infrastructure, such as Wi-Fi, or people don't have the devices to work with healthcare on digital. If there is no trust in the communities on digital healthcare, if there are issues with safety, for example, digital safety issues, or if there are issues with the digital technology capability or literacy, then it's not going to work. So I think that the next big thing is about digital inclusion and making sure that we are improving the digital capability of our population. And again, we are not saying that the same size is going to fit all. So it's going to be according to the population need.
Yeah, thank you. Really helpful reflections. Liz, did you want to come in?
I think I'll let Jill go first because I think she had her hand up before me.
Apologies, Jill, I didn't see your hand up. Jill, would you like to come in?
Yeah, only a little point. Thank you, Liz. It's just that the systems, you've got the technology, and it's across all groups of people and nationalities and that. They're not all digital minded, but sometimes the technology doesn't talk to each other. I'll give you an example in that my doctor, I needed some help, and my doctor asked me to photograph, well, I'll tell you, it's my leg. I had to photograph my leg, email it to the doctor for them to have a look at it. And I did it, I took the photo and sent it, but my system wouldn't talk to the system in the GP surgery, so it just didn't work. So, I mean, I was fortunate that I've got excellent GP and she actually came to see me, but I think that's a little problem with digitalness, that the systems don't talk to each other. So I think that's part of, what delays people clicking onto it. That makes sense?
It does make sense. Thank you. I think that's a really helpful reflection. Liz, did you want to come in?
Yes, it's just, I'm probably adding to some of the comments already made. I see digital very much as having its place within our service provision. It's not a panacea. It doesn't fix all of our problems. Actually, as Paul has said, sometimes it can make them worse. So we have to be quite clever with how we use them. But if we use Jill's example that she's just given, we know that technology can really benefit actually providing the service, you know, getting the image, sending it through, being able to diagnose from that. It can enhance patients' experience, but actually it does not necessarily always replace humans. And actually we really need to focus on the staff who are using the technology and the patients who are also using the technology as well. But that said, technology can give patients choice. It allows them to have options, and it can empower them with information to be able to support themselves. And we would have been pretty much lost during COVID times if we didn't have technology to support us. And there were an awful lot of groups of people who could not meet physically to support each other, peer support for their conditions. So they automatically moved lock, stock and barrel into Facebook, onto WhatsApp. And one of the examples that I use when I'm teaching about accessing medicines when we have shortages is groups of pharmacists working together using WhatsApp to share information about who has stock, where can they get stock. Now that's an informal mechanism whereby we all have phones in the most part, certainly the pharmacist professional community, and they are using that. So they're not using formal systems, they're using informal mechanisms to do it. So technology facilitates and enables, and it's incredibly convenient. So I think we just need to remember, as Paul says, it has its place and we use it very, very well. We have to design it for a very distinct purpose, but we need to remember who's using it as well and the benefits that it realizes for them.
Thank you. Yeah, really good point. And you saying that about WhatsApp, I mean, completely different example, but we've been doing some work recently about supporting people to work in care. And one of the things that we've started doing very recently is there's a WhatsApp group of care managers across the district. And we've started messaging them with people that are ready to work in care. And you think it's really simple, a really simple idea, but it's proving really effective. And and sometimes, it's really simple things like that are the things that really help to make a difference, aren't they? Yeah, thank you. So the next question, I think, this is much more specific, but I think it links to what we've been talking about, but it actually brings it down to what is a specific area of the health and care system. So the question is, how do you think technology can enable us to move to a more proactive, and then it says in brackets, less reactive, so a more proactive approach to caring for older people? So this is kind of taken what was a very sort of high level thing that we were talking about, but bringing it to something quite specific. So I wonder if anyone's got any thoughts around that. Sohail.
Yeah, so technology, the digital technology in older people, I would talk about the telemedicine service, the Airedale. It's a fantastic service. It's running across many areas in the country, but just if we say around Bradford, almost all the Bradford care homes have got access to it. There is a digital care hub in Airedale Hospital that is staffed by very competent and experienced nursing staff in elderly care. All the care homes, they have the kit to identify if they have any problem, any issue, anything. They can contact the telemedicine hub. They can speak to a clinician. They can show the patient on the screen, and it's working fantastic. And we have done a lot. The telemedicine hub has done a lot of work in during pandemic. Proactively, I think again it comes down to the population health management approach using the intelligence and data, and that is a lot of it's the concept of care coordination essentially. So in order to identify the problems before they arise, so identify, for example, people who have severe frailty on the GP registers or on the on the hospital registers, and then wrapping around services around those elderly people. That is another use of proactive data and intelligence and digital technology, and that is again is happening in the care coordination arena. So there are a lot of things going on, but there is a huge potential in using the digital, and especially, for example, remote monitoring of people with chronic diseases or people who cannot come to the housebound people, for example. So a lot of stuff. There is a lot of things we are doing and we can do further in remote monitoring arenas.
That's really helpful. Thank you. Paul, I think you were next.
Yeah, thanks, Tina. And just again, building on Sohail's comments, I mean, I suppose three things for me. One, I think there's formality, and a number of those things that he's referred to are where we've got existing care processes, and what we're doing is enabling people with technology to involve themselves and provide, you know, vital information in terms of the diagnosis or their treatment to us in a way that avoids them traveling or avoids the issue where the contact might be sporadic and therefore it's hard to get a trend. Whereas if you can draw that information in from the person regularly and routinely, then you can identify those trends, and then to use that proactive word again, you can get involved and upstream and try and be more preventative, rather, you know, catch people before they fall effectively, both literally and metaphorically, actually, in some occasions. The other bit is the informal element, and I mean, Liz referenced a couple of things about contact and community and people like me, and the ability both within families, whether those families are geographically close or distant. And I know, again, from my own experience, my mother-in-law lives independently in Northern Ireland. She's in her late 80s. My wife is her only child, so we're the we've got the grandchildren. So if she wants to stay remotely connected to the grandchildren, that's done through video calls effectively, and can happen independently of my wife and I. So she can have a relationship with one of my daughters who's particularly keen on the sort of needlework and crochet work that her grandmother's taught her. So those sorts of informal links, I think, can also be maintained, and they don't involve or require the statutory sector at all. You know, Liz's example about people staying connected through the pandemic with people who share their or managing their condition, I think, is really important. And then the other thing that Sohail highlighted as well is how do we take all of this understanding of how people experience services now and not just model what it looks like for populations, and again, this is where Rosie will have the experience and expertise, but where we take it one step forward and can be predictive for the individual. What's the risk for that individual? We all know our A&E departments are full today, they'll be full next year, they'll be full the year after that. The real key is to understand whether we know who's making up that complement of people presenting, and can we do something really positively with them to prevent that to work upstream. So I think there's formal, informal, and the opportunity to use the data and the insight in the way that Sohail's highlighting.
Really helpful. Thanks, Paul. Jill, I think you were next if you want to come in.
Yes, a number of years ago when I was working, I went to York University for a conference, and it was about telecare and showing how a gadget in someone's home, but through the television, that person could be monitored, whether they got in and out of bed, whether they could be reminded for the tablets. And I thought, this is a marvelous thing, because most people have televisions, but I haven't heard of it for a long time. I don't know anybody that's done this thing. So I wonder if we're moving forward with technology, if we can move forward, but use the television as the means to contact people. So go back a step, because, you know, people with that English isn't their first language, on the television, you can put the screen up, can't you, to help them, or if they can't see, or you use BSL or something like that. There's lots of means that you can use for the television. So I'd like to see that marketed more. If it's still there, I think as patients, we need to know a little bit more about it.
Really interesting, thank you. Now, I know, Liz, you had your hand up next, but I'm wondering, Paul, are you wanting to come back in on that specific thing?
I was just going to jump in on that one,
Yeah.
and without going into the detail of Jill's specific point and the product that I think she might be talking about. It's just that other really important point, which is we don't always need to get overexcited about the next new gadget. Actually, the telephone is very useful in very many contexts, and Alexander Graham Bell, invented that quite some time ago. So, I think her point is well made. There's always that lure or luster of the shiny new thing. I think we should always look at these things in the round and understand whether we can repurpose stuff, particularly stuff people are comfortable with. So if people are comfortable with the television in the corner of their room, and there is a way with their consent and support that we can add some additional functionality to that, then why would we not at least have that conversation, rather than not some sense that another bit of gadget or gizmo has to be added into the mix? Because as Jill also nailed earlier on, one of the other problems, unfortunately, sometimes is the gadgets and gizmos don't all talk to each other quite as routinely as we'd want them to. So in some cases, let's just keep this simple.
That's useful. Thank you. Useful reflections. And Liz, did you want to come in now? I hope you don't mind that I pulled back in.
No, it's absolutely fine. They're all making absolutely fantastic points. I think just to add to the really interesting discussion is that technology that's available now to support people who are living longer, living better. There's so many more options than we ever had before, I think. And actually, it's not just with regards to carers looking after patients, it's patients being able to support themselves, look after themselves, live independently, feel empowered, feel secure that actually they can live within their home, they can do everything that they wanted to as well. And that can be anything from utilizing, Fitbits, watches, or it can be a camera that's in the house, or it can be doing something really cool and advanced, like Jill was saying about her TV. You can get smart walls with sensors, and they can track activity. They can tell you what's going on with the people within the home. They can look at people's, they can match people's temperature. They can see physically that things are changing with them. Now, if we think about the fact that actually data being collected by those devices and being shared with, people who need to know about it, that automatically means that you can address issues earlier with their health and well-being than we ever were able to do before. So I think we just need to remember that actually we have designed really, really interesting products, but actually some of them are very simple and very easy to use within patients' homes to really help them protect themselves and everyone within it.
Really helpful, thank you. Yeah, it's mind-blowing, isn't it? I think actually this leads, there's another question I'm looking at, and I think everything that we've talked about leads quite nicely into this actually. So this question's more, I guess, around sort of how our health and care services are led and managed at a sort of local, regional and national level. So I don't know how many people that are watching today are familiar with the phrase I can't even say the phrase integrated care systems. But so I'm not going to try and explain all of that now, but if it's not something that you are familiar with, it is worth Googling it just to find out a little bit about it. But Paul, I'm looking at you initially, but it may well be that other people want to come in as well. So with the introduction of integrated care systems, which the acronym for that is ICSs, so quite often you'll hear that. What changes will this mean to digital connectivity, and how will goodness gracious me, how will patients be impacted directly by the introduction of integrated care systems?
I mean, I'm sure Sohail will have a view on this one as well, Tina, and I did. I mean, fundamentally, the thing that's underscored by our local integrated care system, and then within this, our place-based partnership, just to get all the jargon out on the table in one go, I suppose there's two things. One, that what often I'm sure fails to local people, that perennial challenge about health and social care and how do they relate with one another. We are challenged to get better at that. And then the other thing critically that we're challenged to do is don't get better at that today, just here and now with the population in front of us and the services that we currently provide, but get better at that in the area that Sohail's the expert in relation to population health management and future generations health and care. So I mean, I think fundamentally it just moves the axis a little bit, changes the nature of the relationships, sets the challenges to those who are professionals in this area slightly differently from arguably the focus that might have been the case in a hospital 3, 5, 10 years ago, which is your job is to treat the people who present at the front door of the hospital, get them right, inverted commas, and get them moved on back out into their own homes. I think in practical terms, our challenge has been, the pitch has been cast, or the challenge has been set slightly broader parameters. Will that make a difference through the digital perspective? Again, opportunities and challenges, because the point that Jill made earlier on, well, we haven't all grown up with the same systems and the same systems that necessarily therefore talk to each other. So, you know, going forward, we've got a bigger challenge ahead to make sure that that information that's captured and the services that are supported by technology in social care and in healthcare can all in some wondrous way join up around the individual. It's not impossible, it's just, it's the right thing to do, and it's a challenging thing to do.
Yeah, useful, thank you. And you answered that a lot better than I asked the question, so thank you, Paul. Rosie, you put your hand up. Did you want to come in?
Yeah, so I'm no expert on integrated care systems at all, but I do know that population health management is like it's the shiny new term that everybody's using now, which are sort of deeply embedded within integrated care systems. And I think my sort of layman's understanding of that, it's about all the different services clustered around an individual, integrating with each other, speaking to each other, sharing information with each other. So you have this, you know, a person, I don't use the term patient, we deal with people. A person only has to tell their story one time, and the people that need to hear it can hear it. We've got a great project in Barn and Bradford called Connected Bradford, which links the information that all these different services collect about people in one place. So we, you know, that's really helpful because it helps to look at pathways, you know, so when do people go to GPs, and then when do they go to the hospitals, and what happens with social care or other services within the voluntary sector. It's really important to have that data sharing and data integration. And to give you, I guess, a concrete example that will help you think about how that all works. So as our Barn and Bradford children, over 13,500 were growing up and started landing in primary schools across the city, we realised really early on that educational outcomes are so linked to health, but education was in one silo and our, you know, health system was in another silo. And we found that there was problems with children's literacy because children who needed to wear glasses, teachers weren't aware of this. So whereas school nurses were able to see, well, yes, this child has a problem with vision, they need to wear glasses, they were not able to pass this information on to teachers, so that when children didn't come to school with their glasses, the teachers didn't know about it. So by linking those two systems up, you're able to then make a real difference for children's lives. So we started a project called Glasses in Classes, which is whereby we were able to identify children who had issues with their vision. We were then able to work with the schools to give them extra pair of glasses to have in school, and we found really good outcomes. So I think that's the really exciting thing about ICS is that potential to link up and be really people focused rather than service focused.
So have we lost Tina momentarily? Is that what's happened, Hannah? Okay.
It is, yeah.
That being the case, shall I just take over and do a bit of linking until we manage to get her back? Maybe your technology on one of those laptop screens has failed for her.
Yeah, that'd be great if you could. Thank you, Liz.
You're welcome. Jill, would you like to join in and add to the discussion, please?
Yeah, just my point about a few years ago, there was an expression going around in health, nothing about us without us. And I'd like to see that reinstated. I mean, if you get your researchers, you get industry and patients working together, I think that would be a real positive outcome for patients in the future. And often it just takes a little bit of common sense. A patient can often solve a problem themselves, but they don't always feel comfortable in challenging, do they, health professionals? So I think if we could reinstate that about, you know, remembering that patients are the centre of it, or people, as Rosie says, they're the centre of what we're trying to do, aren't they?
They are indeed, and that's a very profound statement, Jill, and that is something that we definitely should remember. Everything we aspire to do within our health and social care is patient-centric, or actually I would go as far as person-centric or citizen-centric, because we remember the fact that they're not just a patient, they're a person as well. So we do keep that in mind, and I think that is what we aspire to deliver to. Sohail, do you have something that you'd like to add to it as well?
Yeah, I think it's. I know that what Jill was talking about, and I think it's fair to say that in the place-based partnerships and the integrated care system, patients and communities and people, they are really integral part of it. And for example, in Bradford, when we are developing the place-based partnership in Bradford District and Craven, we are creating people forums and citizen forums to assure us, to provide assurance to the board level discussions and decisions that whatever we are doing is taking people and community views into account. I think in terms of the question that what ICS could add to the digital, as Paul said, I mean, the main thing is that we want systems to work together, talk to each other, and provide a full, richer picture of a patient or a person's life and what is happening in the population. So both at individual and population level. And obviously there are loads of obstacles in bringing that data together, and not just within healthcare, but not just across health and social care, but within healthcare itself, like primary, secondary, community, mental health, and all that. So with the ICS, hopefully there will be a bit of reduction in those barriers of bringing the data together. And also there are opportunities of pooling the funding and the work that is happening in silos in different organizations, different sectors. For example, in Bradford, there is a digital strategy of Bradford. There is our Act as One digital program. There are other digital programs going on. So how can we bring it all together and pool the resources? So I think that is another thing that it will give us the opportunity. Thank you.
Thank you. So, Paul, if I might ask you a question, because obviously Sohail has commented on the different digital strategies, and obviously ACT as One as a stakeholder group all working together, their ideas and their ambition is to make sure that Bradford supports all of our patients, make sure they're healthy, happy, live longer lives, etc. So I'm just wondering, is there anything more that we need to know or just to discuss with regards to the digital aspect of that, that connectivity across all the different stakeholders?
I mean, I like Sohail's last point. I've got a new slogan now, full, richer picture. I mean, it was on a page as well. I mean, I think individual organizations will always have a story to tell, because the primary audience for those stories often is their own workforce. And there will be aspects of what we're talking to and about with colleagues who are delivering mental health services, which will be slightly different from colleagues who are delivering physical health services. And then when you get into physical health services, there'll be some procedures and some relationships with patients, citizens, our public, where virtual is more of an obvious aspect of that, and where in some disciplines it's less an obvious aspect of that. So I'm not so anxious about, have we got one story to tell here, or have we got many stories to tell, as long as those many stories are chapters in the same book. And I think that's definitely a possibility here. And there's definitely, you should be also able to read those chapters and see some common threads. I mean, I go back to Jill's earlier point about, there's a horrendous word that I was trying to avoid, and I've avoided it for 57 minutes, which is interoperability, which basically means that the information captured in one place is available in another. That's basically what it means. Can I tell my story once, and can everybody who has a reasonable reason to get access to that information get access to it? So I'm not, I'm pretty positive about the fact that we're more joined up than we've ever been. We're more engaged with the communities and with individuals like Jill than we've ever been. But I'm in no way complacent about the fact that we still need to do quite a lot of work, and that we need to really, I mean, the point that I hope all of us have emphasized it, but Rosie's emphasized it from the outset, is that we're here at the disposal and to serve the interests of our communities. They're the people who know what it's like to be a kid in Bradford. They're the people who know what it's like to live, and thrive in Bradford. We need as many ways into all of that understanding, insight as we can practically get. And we need to be very careful and very conscientious about some of this information and data. I'm sure there are people thinking about, I mean, Liz, you mentioned your intelligent wall earlier on, that's has a touch of sci-fi about it, doesn't it? And I'm sure there are people thinking about, my God, I'll just run to the moors here. I'll just want a bit of peace and quiet away from all of this technology, So we've got to get this balance right, and we've got to make sure people are clear about the benefits and are have positively given us their permission to do some of this sort of stuff, because elements of it will be experimentation, and I don't mean experimentation with lots of risks, but some of it will be experimentation, because some of these things some people will get on with, and some of these things other people will get on with, and we just need to work our way through them.
Fantastic. I'm just wondering, again, is there a fine line and a balance between, let's just stick to the digital, because we've been talking about that a little bit. Is there a fine line between the balance between what's acceptable to put out there for patients to support their care, and never put in front of a patient, because it might send them, as you just described, Paul, run into the mirrors? At what point does sort of responsibility and sort of ethics kick in with what we can do with technology? Rosie?
I mean, my immediate answer to that is that we should always be working right from the very start with our communities so that we understand what's acceptable and feasible. And I think in Bradford, I think we're pretty good at that in Bradford, and maybe not so much in other parts of the UK, but the idea, communities should be at the heart of everything that we do. So in my aspirational world, we never get to that point of trying to drop something in that people aren't happy with.
That's fantastic. Completely agree, Rosie. Paul?
No, I'd underscore that. And then the other thing I'd say as well is that we should also not assume that people won't get on with some stuff. So that I don't know whether Jill regards herself as a silver surfer. I know I'm getting very, very close to being a silver surfer myself. But, that idea that somehow there's an age barrier to this, or that some people with particular mental health issues or behavioral disorders will be particularly uncomfortable or not wanted to engage with this. Well, that might be true. We might have to have a much more sensitive and a proper conversation with everybody. But we should do it from a position of, it's an offer. Do you think this is something that you will get on with? Not an assumption that it won't fit the bill. But equally, it does then open up a whole hinterland around skills, access, confidence, all of that stuff, and another piece of jargon which colleagues can go and look up is increasingly called inclusive digital transformation, because you can't do it without that element and dimension of inclusion at the forefront of it as well.
Fantastic. Thank you very much, Paul. That's really enhanced Rosie's point. Sohail?
Yeah, so essentially, I think the first thing is to be open, honest, and transparent between the services and the community. The second thing, obviously, is the mutual respect. So if the community, there is a thing called, the community readiness. So if we are not ready as a community, as a society to do something today, we respect it. But then the third thing is not to take, it's a ever evolving field. So the context that is today might not be the context that is tomorrow. And the understanding about the risks, about the interoperability, all that changes. The community, the society context changes. So it has to be fluid. So I think it's just that as long as we are open, transparent, respectful, and fluid, I think we can just continue to. But the main thing is we cannot and must not do it in silos, because that then causes distrust. And if there is a distrust between service and community, that is not going to help anyone.
I think the last couple of years with the pandemic has shown us how fluid and how responsive that the NHS can be, will be, continue to be, and actually how creative and innovative they are with regards to solutions as well. I've no doubt that ingenuity and that creativity will continue. Jill?
Yeah, a bit from what Paul said. I don't think age is anything to do with it. I think in the heart of it all, it's patient choice. You can get, I used to work with a community group, and some of the members of 80 or 90 odd were far more advanced in their thinking than some at 50 and 60 odd. So I don't think age is a barrier, it's a presence of mind. And I think when we're doing anything with patients, we've got to give the patients a choice. I mean, we talk about Bradford, but sometimes, and this might sound a bit controversial, we talk about Bradford, but only as the centre of Bradford. We forget that Bradford is a wide district, and you get rural communities, town communities, and city centre. And so to please everybody all the time is absolutely impossible, isn't it? But as long as we consult as wide as we can and market everything, then I think we're trying to do our best, really.
And I think, the NHS do an amazing job looking after all of us, but I think it's always the case that we can be reminded that there is more that we need to do, or certain groups that we need to look after more. And I think this would neatly bring us on to some of the areas that Sohail can talk about with regards to some of the work and some of the projects that we're doing within Bradford to address inequalities. Sohail, would you mind giving us a bit of an insight into that?
I mean, yeah, that's obviously the favorite topic, isn't it? So yeah, I mean, in terms of the health inequalities, obviously the first thing is what these are. So essentially we define these as avoidable, unfair, systematic differences in the health status or in the distribution of health resources between different groups of people. And we know the health inequalities are not just because of the healthcare services, but it's multiple factors. It's where we are born, where we grow, where we live, where we age, the distribution of health resource, workforce shortage, for example, in areas of highest deprivation. All of that contributes to health inequalities. And the picture in Bradford, I mean, Bradford is really, really diverse. We have, for example, Wharfdale is in the top 10% of most affluent areas in England. Manningham is in the bottom 10%. It's the most deprived area of England, and there is 10 miles between the two. And within one of our program, Reducing Inequalities in Communities, we mapped the bus journey from Wharfdale to Manningham. And if we ride from Wharfdale, the life expectancy of someone living there is about 85, 86 years. And when we come down to Manningham, it comes down to 84, 85 years. That is 10 miles, 10 year less life. And then the healthy life expectancy, how long people live in healthy life, is even stark. There is even starker difference. There is about 10, 20 year difference between these 10 miles. So that is the picture, and that is just come on. It has just gone to in COVID. There are these inequalities have been stark. So what are we doing? It's because it's a combination of social service and community factors. We have to work on all three levels. So at social level, it's about the colleague from Bonn in Bradford is saying, it's about work on employment, education, housing, transport, healthy food, greener, safer places for our children. And we have our Bradford Wellbeing strategy. It reflects this commitment. Our City of Culture bid, for example, it will help in the economic recovery. At community level, it's about celebrating diversity, culture, taking initiative to generate health by promoting healthy lifestyle, self-care, taking care of each other, building community resilience, building health champions. And we are working a lot with our voluntary and community sectors to harness that. And then healthcare specific. For example, there is work going on improving the workforce situation in deprived areas. We know there is huge shortage of doctor, clinical, nurse, healthcare, and all the workforce in UK, in Bradford, if we say. And we also know that it's not equally distributed. The areas, for example, Manningham, the worst areas of deprivation, where there is a huge need, we do not just have the workforce. We just cannot attract that workforce to those areas. We have to work together with communities to attract people to come and work in those areas. And programs like RIC, for example, we have a program in working in the Central Bradford. It's a multi-million-pound program. There are 21 projects across the workforce. Across the lifespan. One of that is about increasing the workforce, improving the workforce shortage. A lot of that is around harnessing the power of communities, things like welfare benefit advisors in the community, things like proactive care team, the care coordination concept that I was talking earlier about. Recently, this Monday, the NHS director, Dr. Bola Ovolabi, she's the NHS director of inequality. She came to visit Bradford and to visit the RIC program, specifically a couple of projects. And one of the project is doula project. So these are volunteers. These are women who work with other women in pregnancy, during childbirth, and that's a fantastic project. And with huge success. There are projects around homeless people. Our Bevan House, there are lots of things we are doing around homeless people, but it's just not enough. And we just have to work together. There is a huge shortage of services out there. Demand is just ripping, out supply, and we have to work together in order to do something around that.
And obviously it may have been that the situation was exacerbated courtesy of COVID as well, because shortages, staff being sick as well. It's a challenging time in order to try and make progress in areas, because with all the will in the world, maybe you just don't have the staff to make that happen. So I suppose if we're finding it frustrating, within the clinical profession, or even as a panel, our patients are probably thinking, it is difficult. It is very challenging too.
Exactly, and it is very difficult, and we acknowledge the issues that people are facing, but it's just being how we work on it. We have to work on it together. And it's working on demand and supply on both ends.
Yeah, that's a very important part. I'm just wondering, Rosie, if from a Born in Bradford perspective, that you've got something to add with regards to, the inequalities aspect and the use of the data to address some of these, courtesy of Connected Bradford, etc.
Yeah, thank you. And I've been getting distracted as we've been going along with the chat and trying to pop a few things in there as well. But Carol actually made a really good point in the chat, which is we've been talking about health inequalities for a very long time. And what is, are we improving? Are we making a difference? And I think looking critically at how we're doing, I'm not sure how well we are doing tackling health inequalities. I think Sohail said it there, even within our district, we have a 10-mile, 10-year difference. And I think part of the problem that we've been having is that many of the initiatives that we tend to try to implement are disproportionately benefit those in less deprived communities, because fundamentally some families who are living in the most deprived parts of Bradford have a triple whammy of issues. They, limited living in poverty, poor environments that they're living in, reduced life opportunities for the children. So actually, we really need to be moving away from the individual approach thinking, how can we mop up when people attend our services, to thinking, right, hang on a minute, what can we do at community? What can we do for these neighbourhoods? What can we do about poverty? The poverty and deprivation is one of the most pernicious influences on any health indicator that you can think of. And that's where we should be focusing our efforts. We should be focusing on initiatives that are going to benefit people living in the deprived communities the most if we want to make the biggest impact.
Thank you so much, Rosie. Right, I'm going to hand back to Tina now.
Thank you, Liz, and apologies. It's just always the way, isn't it, that when you're doing something like this, my internet just died completely, so I'm really sorry about that. And obviously feel like I kind of missed a bit of what you were talking about as a result. But so I'm just looking through some of the questions that got sent through previously, and there's, I think, some things in there that we've touched on, and I'm wondering if whether it's worth going back to any of it a little bit. So there was a specific one, Sohail, I'm looking at you particularly. So there is a question that came up, and I think you've touched on this a little bit, and I don't know if you want to say any more about it. So it's really around the population growth. So the fact that, you know, the population in Bradford has grown. We know that the impact of the pandemic has caused real issues with waiting times. So I suppose the question is around how realistic is it that we can cut waiting times with no extra money? And then kind of linked with that is around the plans to improve services. So you have touched on that a little bit, talked about working together, but I'm wondering if there's anything more that you wanted to add around that.
Yeah, these are really great questions, you know, and I think we have to, you know, we cannot shy away from this as a system, and they need open and honest discussion. I'll just say I was recently attending a workshop on value-based healthcare for the ICS leaders, and there is a concept. It's called tragedy of the commons. And what it essentially means that when the resource is limited and it's common to everyone and the demand is unlimited, it will ultimately overrun supply, and ultimately the resource will be lost for everyone. And if we look at any predictive modeling of the healthcare supply and demand, there is a consistent picture. The supply of healthcare service is much less than the need and the demand for the services for whatever reason. And I think we have touched a lot on those reasons, that the reasons for that are beyond the healthcare sector. It's our communities, the education, it's the employments where we live, where we grow, all of that, plus the access to the healthcare, the shortage of the staff, the inverse care law, I think someone put in the chat, that was from the Julian Tudor Hart in 1978. And essentially it means that in the areas of highest deprivation and the highest need, there is lowest number of workforce. So, but the tragedy of common can be managed by stewardship. And the stewardship is a sense of responsible ownership by people who use the resource and people who provide the resource. And in our context, it would be our communities, our people and professionals like myself, like Paul, like you, all the services and communities. It comes back to that. So how we make it truly universal and accessible for people who need the NHS, we have to work on multiple fronts. So it does not end, the responsibility does not end when we pay the tax. It only starts there. We know, you know, we have touched on the thing, there is a pandemic of obesity in UK. In Bradford, there is a pandemic of obesity. 40% plus of our school-age children are in obesity. And the distribution is not fair. Distribution is not across Bradford. A vast majority of those children and those adults are living in the deprived areas. What does it mean? It means that there is a lot of diabetes, a lot of hypertension, a lot of health disease, a lot of health demand, a lot of cardiovascular disease in the deprived areas. Then there is, every year we spend billions, we waste billions on medicine wastage. Billions of our pounds are wasted when people do not attend the appointments. So, and the issue with the access to the primary care is also causing a lot of anger, also causing a lot of anguish, and we understand that. So improving service, for example, what are we doing, or what we can do is to mean new models of care. For example, digital access. We're talking about digital, online services, funding in the areas of highest deprivation to attract more healthcare professionals, new technologies, introducing new roles. I think there was one question about social prescriber role, introducing new roles in the primary care. But that is not enough. The stewardship would mean self-care and taking care of each other. If we use online resource, for example, when we develop a minor illness, or we attend our local pharmacy, If we buy a medicine over the counter, if we can afford it, if we use all our repeat medicines and make sure there is no wastage, if we try to eat healthy, if we try to adopt healthy lifestyle, if we try to increase our English language literacy to reduce demand on our interpreting service, if we make sure that then we are asked to attend a diabetes appointment or cancer screening appointment, we go to that, that is all going to reduce demand on the healthcare service, and the NHS will be accessible for people who need it. And all of the above of it all is the social infrastructure, community resilience, education, employment, greener, safer spaces. But I will again go back. The key is working together. Key is working together. We can spend billions on, for example, digital infrastructure. If people don't use it, they don't have trust on it, or they don't have the ability to use it, what can we do? And Bradford University, I am looking at this institution. It has tremendous, I would say, we can turn this around working together. The majority of students working in Bradford, studying in the Bradford University, live in Bradford. They are part of Bradford families. Those families are registered. Those families are the people who are, who need to access healthcare services. Let's say every student aims to do a little bit within the immediate family. We can turn access issue on its head. If we can train every student in how to use digital healthcare, very simple guide, how to send e-consult, how to make appointment, how to use video consult, how to use NHS app, that student can work within their area of influence, within their family to educate more people. We can work together on increasing English literacy. We can work together on increasing self-care awareness. We can work together attracting more people to come and work in our amazing Bradford. Just imagine how amazing it would be if the BD8, BD5, BD6, BD4 communities are sharing the campaign and attracting doctors and healthcare workers saying, come and work in this area. We will give you the respect you deserve. We are a great, vibrant community. You will love working here. How big, how will that be? Then I will just touch on the social prescriber. I think that's an important thing. These are part of the new roles coming to the general practice. So social prescribers. And this is essentially, it's because a substantive number of people who attend the GPs, it's for social issues or the symptoms that arise from social circumstances, and the treatment is not medical. So social prescribers, they can help connect people back in the communities with the key voluntary organizations to help their real issues. And similarly, there are other people coming into general practice. For example, first contact physiotherapist. A vast majority of the GP contact is about back pains and joint pains, and they are treated with painkillers and physiotherapy. And the first contact physiotherapist can see the patients directly without having to wait to see a GP or a nurse or advanced practitioner. But the key is to make these a success is by improving the people trust in these services and their capability. And for that, I will go back. We cannot do it alone. We have to work on it together. I will stop here. Thank you.
Thank you. Yeah, really important. And actually, I was going to just ask a little bit more about that social prescribing role, because it's a really good example of some of that work around new models of care, isn't it? I think you did talk about it a bit more, but as you've just said, actually, crucially, it's how we build that trust in talking to somebody that's not the doctor, isn't it? Because that seems to be what's built into us, isn't it? As we phone up the doctor's surgery and we want to speak to the doctor. And you were talking before about what we could, the sort of, I imagined as you were talking about the work we could do with the university, I was imagining that sort of ripple effect. And I suppose there's something around that with how we build that trust in our local communities as well, isn't there?
Yes, and I would say that we are, I think I mentioned that we are creating this Reducing Inequalities Alliance in the Bradford place. And the head of University of Bradford School of Pharmacy, Heather Zaman, he actually approached me and he said, I want to be on that alliance. And we did discuss about that if we can do some sort of pilot with the pharmacy students, one about this digital health literacy and using their influence within their families to increase the health and digital literacy. And the other thing about students who are in the healthcare, for example, the Bradford University students, how can we bring them into the placements in deprived areas? So within there, so increase their understanding of working with deprivation, but also enhance their passion. So when they are coming out, they would like to work in the deprived areas. So there is a huge amount of stuff that we can do together with the Bradford University, and we'll be working on it.
That's great, thank you. Rosie, I know you patiently had your hand up for ages. Did you want to come in?
Well, it was just like, I vehemently agree with everything that Sohail has said there, but it was just when he was talking about the demand issues, and I guess I just wanted to reflect back to my elevator pitch, which is all around prevention. And prevention is so important. We need to stop people getting to the point where they need to rock up at the A&E or the GP surgery. And the issue we have, you know, the public health budgets are tiny, 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 and they keep getting cut. So there's a real issue here that we need to address at a government level. It's about prioritization. And the problem that we have with spending for prevention is that it is very difficult to quantify the impact of that. You are stopping things happening, and it is really difficult to then say, well, this is what we have not spent in our NHS treating this issue. So I don't think we're going to solve it in the next 6 minutes, but I just wanted to raise the flag for having that not losing the focus on the fact that much of these issues are preventable.
Yeah, thank you. A really important point to make again. I am mindful that we're nearly at 7 o'clock and the time's whizzed by. Liz, sorry, you've got your hand up. Did you want to come in?
It'll be a quick one. Again, one of the comments that was made earlier on was about environmental changes. And it just struck me that actually a lot of what we can do to support our patients and their mental health and well-being as well as physical is to make their environment better. So it's not the physical treatment in a hospital or GP surgery or even medications. It is that someone to talk to. It is that referral to a group to get peer support. But it is actually, you know, working with our local council to make our environments just more convivial, you know, leafier, greener, because that automatically puts you into a better frame of mind, whereby maybe then you do feel your day is a bit better, and maybe then you're able to, you know, manage your condition a little bit more. So it's little things like that that we need to consider as well, that they do complement and they do enhance our, you know, our healthcare offering, I suppose. And so we shouldn't forget the extras, the non-traditional ways to advance healthcare agendas.
Yeah, thank you. Good point. Jill.
Yes, we talked about our partnership and working together collaboratively, haven't we? The industry, the university and that, but we haven't mentioned the voluntary sector and what a powerful tool the voluntary sector is for helping. I mean, I've helped set up groups and I work with a voluntary sector group in Manningham, funny enough. And you know, we see all sorts of people that we try and help. So I think perhaps years ago, volunteering used to be very popular, but it's got less popular these days. I don't know why. I don't know whether we've got more selfish or what it is, but perhaps that's another area, having volunteers to support other people, support them in any area of Bradford. I mean, we don't ask where people live when they volunteer, do we? It's to help the community. So I don't think we can, you know, push away the voluntary sector. They're all part of this collaborative to help one another and to work as a community. And it doesn't matter where they live, because I get the feeling sometimes that, and I will own up, I do live in the Wharfdale area. We get accused, oh, you live over there, you're all right. We have the same issues and we're not being selfish. I mean, I moved from London. I'd never heard of all the areas around here. I just moved, being married a Yorkshireman. But I think that we've got to stop sort of thinking as centre or something. We've got to look at us really collective as a district, and one district could help another district, couldn't they? You know, a lot of people in the Wharfdale area are free to volunteer, so they can perhaps help those in the deprived areas. You know.
I think that's such a good point. And I think just thinking back actually to what Liz was just saying, you know, and the point that Sohail made earlier, actually, it's not just about what health can do, or even just what health and care can do. It's a whole district approach, isn't it? So taking on board, you know, the things that were talked about how we can, you know, have a better environment and can bring health benefits. So who do we need to connect with to look at that side of things? And then, you know, your bit about bringing in volunteers, there's all sorts that people could be doing. So I suppose there's a question about how much is already happening in terms of those, why it's the wider determinants of health, I guess, isn't it? And I suppose it's not something that I particularly know that much about around what's already happening. So Sohail, you've got your hand up. Did you want to come back in?
Yeah, so in terms of the voluntary and community sector, a lot has been happening in Bradford and across West Yorkshire, and VCS are our what we say equal partner on the board level and at ground level as well. And essentially the integrated care system cannot succeed without the involvement and empowerment of and funding, you know, use of the voluntary and community sector in all the ways that Jill you know described. And so a lot is happening, but a lot needs to happen. The RIC program that I touched upon, about 30-40% of that RIC program is actually spent and delivered by our voluntary and community sector colleagues, but they are part of the pathways. It's not just a nice thing to do it at the side. They are part of the pathway of care, and that is where we want to bring the voluntary and community sector as part of our offer to the communities. And the other thing is, I know the danger when we generalize things. So yes, there are issues in highly affluent areas as well. There are pockets of deprivation involved as well, and I think that takes us back to the connectivity of the data and looking at the population health data in terms of the smaller neighborhoods. So we do, when we look at the whole thing, we do not just neglect, you know, the issues that each community is having.
Thank you. Yeah, really important point to note, isn't it, that how well the voluntary sector are actually connected into that whole health and care partnership. So I'm really mindful it's 7 o'clock, and we did say that we would aim to finish around 7, but it does feel like a good conversation. There's one question that's come up that's very different actually to what we've talked about so far, but it feels important to me that I do ask it. And Jill, really, this is I think predominantly focused on yourself, and I know it came up in the chat earlier. So it's really your role and how other people that might be interested in doing something similar, I suppose, how do you get involved?
Are you talking about the working with the university?
Yes, sorry, yes, yeah.
Yeah, well, Bradford, I've worked with other universities as well, but Bradford are quite unique in that they've actually employed somebody that's called service user lead. So we have a lady that looks after the service users. And I think in our group, we've got up to about 45 of us, and from all ages, all walks of life, you know, nobody's left out that wants to join. And so we cover a lot of different health issues. So that's beneficial to the students that they can come. So if you Google Bradford University and contact the School of Health, then you can sign a form and put your name forward to see what you're interested in. As I said before, I think I've been doing it for about 10 years. And I think it's part that mentally helps me, because I'm living with a long-term condition, and I've had some good care and I've had some perhaps not so good care. Often it's when health professionals are having a bad day at home, they have a bad day on the ward or something like that, so they seem grumpy. But on the main, I've had some very good care. And you'll sometimes hear patients say, I want to give something back. So perhaps that's the theme of our group. We feel that we've accepted healthcare, we've had some good healthcare, but to give something back is helping to train the healthcare people of the future. So I think you get a real sense of satisfaction. And as I say, Bradford University are quite forward in that, in involving, you know, patients and carers, not just patients, but people with lived experience, that they can share their experiences and learn from the mistakes and then advance the positives, really. But always remembering that whatever we do in health, it's patients that are the centre of it all, and that's why we do it, isn't it?
Absolutely, thank you. Yes, really useful to hear that. And I think, you know, the conversation that we've had tonight really demonstrates the power of and the value, I think, of involving patients and service users in this kind of work. So thank you. And I know it did come from the chat earlier where somebody said, how do I find out more about it? So you've told us that now. Really appreciate that. Thank you. So it's nearly, well, it's after 7 now. I'm wondering if there are any final points that any of our panel would like to make, and I'm just going to have another quick look at the chat to see if anything's come up that we've missed. But are there any final points that any of our panel would like to make before we leave tonight? Liz, over to you.
Building on Jill's final comment, it's integral to anything that we do within our research that we have the voice of the patient represented, because how can we design a service or a product, be it digital or other, if we don't know what they need and if they don't tell us how they will use it? So they are critical to the design and the implementation and the acceptability of it. We rely heavily on groups of amazing people to support our research by contributing to it and actually working with us the whole way through our research projects and being our co-authors as well. So we really do value their expertise. So if anyone is interested in following Jill's footsteps, please do get in touch, because we would love to have that discussion with you.
That's great. Thank you, Liz. Any final comments from anybody else? Okay, thank you. Oh, so there's a poll that's just popped up on my screen. So if people could just take a 30 seconds to complete that, that would be really helpful. Thank you. And thank you very much for all of our participants. Thank you for sending your questions in advance, because they help to get us thinking about what we would talk about tonight. And thank you for those of you that have contributed through the chat with your comments and your thoughts. That's really helped to keep the conversation flowing. So we really appreciate all of that. And thank you to our panel members, just really interesting insight from you all, and you've all complemented each other really well. I found that really interesting. So thank you. We have recorded the session, so I'm assuming that parts of that will be available for use afterwards for different things. But for tonight, thank you ever so much, and enjoy the rest of the evening. Thank you.